Today, I'm going to speak about intra-articular fractures. Do we need external fixation? I'm going to talk about the 18th International Cairo Deformity Conference. It's going to be from 3 to 5 August 2022, next week in Intercontinental Stars. I hope all of you can attend. It's a very important meeting. You know, this paper published in the Journal of Bone and Joint Surgery 2017. The very popular annual deformity courses are Baltimore, Hull, and Cairo. In Cairo, we have about 12 workshops. What's the difference between Hull, Baltimore, and Cairo deformity meetings? We concentrate on the clinical workshops, clinical background, not the drawings and lines. So I would like to welcome all of you the next week in the deformity conference. Intra-articular fractures are complicated injuries. You all know the osseous injuries. We all know it. And there's also a soft tissue injury, which is usually underestimated, especially if it's a closed injury like here. It's an open injury, we all know, and some people can classify it. But what about the closed injuries? It's usually severe closed injuries. Sometimes you have just a fissure, intra-articular fissure, but you have severe soft tissue injury. What are the complications of intra-articular fractures? These fractures can damage the articular cartilage and subchondral bone and lead to articular incongruity and step off, as you see here, and instability, ligamentous instability. The principles usually are anatomic reduction, stable fixation, early mobilization. Conventional teaching usually present the methods of reduction, non-invasive, minimal invasive, or invasive. And usually they end up with internal fixation. In the three situations, they end up with internal fixation. So most of the papers are talking about internal fixation and evolution of the implants from just regular plates to polyaxial plates and nails, things like this. And when we talk about intra-articular fractures, we talk about the reduction, open reduction. But remember that open reduction means more soft tissue injury, like this case. You see the huge and the significant soft tissue injury. If you do open reduction and you do more incision and dissections, you add injury to the injury, but this is the conventional teaching. And remember that open reduction is not without complication. It's not without serious complications. Remember, infection, deep infection, protruding plates here. Deep infection in the elbow. Deep infection in the knee, you see here, an absorption of the fragments. It's really a serious problem. So open reduction, you add injury to the already injured part, you add more soft tissue injury, also you have serious complications. Again, sometimes you cannot gain acceptable reduction. So if you don't gain an acceptable reduction, you have to take the patient to the operating theater again and do revision of the open reduction, which means more soft tissue injury. Again, like this unacceptable reduction, you see in the sagittal plane, more than 1 centimeter. Again, what do you mean by external fixation? People call this external fixation and that external fixation, and that plate external fixation. TSF is external fixation. So is they all the same? This is not true. And people talk about limitation of external fixation like this one. And people, they want to show the external fixation as Frankenstein. Now we go back to reality. What's the role of external fixation? We have temporary external fixation and definitive external fixation. Most of the conventional teaching talks about temporary external fixation. but they don't talk about the rules of temporary external fixation. There are many rules of temporary external fixation that you have to consider before application. The method of the application, the time of the fixation. Time of the fixation is a crucial factor. Temporary external fixation in the emergency department. Sometimes the patient in a critical situation, and you just need to fix the bone to reduce the shock stage. So sometimes you need to do two-stage fracture treatment. You see the tibial plateau fracture with this severe soft tissue injury. You cannot do open reduction, so you put external fixation. What are the rules of temporary external fixation? Rapid stabilization, pain management, minimal blood loss, easy access to the wounds, improve patient's mobility and nursing care, diminish further soft tissue injuries, and facilitate the radiographic evaluation. Rapid application. Sometimes you cannot have an intraoperative X-ray. The patient is dying within few seconds, so you just apply it without an X-ray control. The pins should be placed so that they do not interfere with the planned later definitive fixation. لازم الهاف بينز تبقى بعيدة عن planned internal fixation. The pins should be placed so that they do not interfere with the planned later definitive fixation. Pre-drilling and the insertion of the hand, or sometimes self-drilling pins. Patient in extremis, the patient is going to die within a few seconds or few minutes. So we apply self-drilling pins and accepting the complications. Sometimes you've got microfractures and infection. You have to avoid the site of the fracture, like this one. You see, he put all the half pins in the fracture site. And you have to stay away also from the joint. Don't put it like this one, intra-articular. You see, you have to avoid the fracture site. Stability. Sometimes the stability is not the rigid stability because you need it only for such a short time. You need it only for 10 days, for 1 week. So you don't have to apply all these half pins. And you have to avoid the intra-articular part and the joint capsule. I respect the anatomic requirements. Of course, you have to respect the neurovascular bundle. Sometimes in intra-articular fractures, you can apply joint bridging like this one, or crossover, but for just a temporary period. Because if you apply it like this patient for 4 or 5 months, you are going to see joint stiffness of the joint. This patient has crossover for more than 5 months. This is such a long, long time. The out majority of the people or the surgeons, they prefer to have used this, the rule span, scan, and fix, or scan, span, and fix, and two-stage operative procedure. You put an external fixator, radiographic examination, then you apply internal fixation after removal of the fixator. Two-stage protocol. Surgical timing, usually within 10 to 2 weeks. This is important. If you let the patient in external fixator more than this, you are going to have severe infection. Like this patient with open fracture, external fixation, stayed in the external fixation for 5 weeks, then we have infection. Thinking inside the box. Most of the conventional teaching are following these steps. Temporary external fixation till you've got healing of the soft tissue, then internal fixation. This is thinking inside the box. Every problem needs only one solution, therefore finding more than one possible solution is a waste of time. In this lecture, we are going to discuss what are we doing, what you can do with the external fixation. And the following questions. Can distraction alone reduce the fracture? What about if you have a large metaphyseal gap? What about polytrauma patient? Failure of reduction, closed or open. Infected cases after primary treatment. What about infected internal fixation? CT, we usually do CT with 3D reconstruction, which provides additional information about the fracture configuration. Number, position of articular fragments, presence of impacted articular fragments, and any metaphyseal extension. CT scans changed the operative plan in 64% of patients and added additional formation in 82% of patients. What's the value of external fixation? The value of external fixation in the intra-articular fractures is closed reduction techniques. This is the real merit of external fixation. You can reduce the fracture without any incision, operative, during the operation, or post-operatively, or during follow-up. So the real value of external fixation is closed reduction techniques, not to use it as a temporary method for 1 or 2 weeks. No, this is not true. The real value of external fixation is the application of closed reduction techniques, and I'm going to teach you some of the closed reduction techniques. Some of them, you can do it while you are sitting in the outpatient clinic without anesthesia or analgesia by gradually reducing the fragments 1 millimeter per day in the sagittal, coronal plane, or rotational or correct rotational deformities. This is an example. This is comminuted fracture tibia, whatever the grade, by condylar, comminution, intra and extra articular fragments with the bone gap. And you see the soft tissue injury. Some people say you have temporary external fixation. Why do I do this? After 6 hours of the operation, we admitted the patient to the operating theater, and under epidural anesthesia, I'm going to tell you the steps as if we are together in the operating theater. First step is to do aspiration of the effusion. Then manual reduction using your 2 hands, and manual distraction with the assistant, and manual manipulations. Usually you don't have to apply the frame proximally and distally and do severe distraction because of the so-called ligamentotaxis. We don't believe in ligamentotaxis because many of these fragments are not attached to the soft tissue. So how, when you apply distraction, the soft tissue will correct the deformity? This is not true. So we just apply manual distraction. So aspiration of the effusion, manual distraction, and manual manipulation of the fragment. You see my fingers because they do manual reduction. Look to the articular surface. With the manual reduction and aspiration and just manual distraction, we've got almost anatomic reduction of the articular surface. So the first step, we had anatomic reduction. Then we noticed the metaphyseal gap, about 5 or 6 centimeters metaphyseal gap. Forget about it now. Then we apply the first wire parallel to the joint to fix the fragments or the intra-articular fragments. Then we apply 2 olive wires opposite each other. Why? To fix the intra-articular fragments. We don't apply traction to the wires. Don't apply traction. Just put the wires opposite each other and pull them by your hands. Just pull them by your hands without any distraction, without any traction. You see 2 olive wires opposite each other, and you pull them by hand to close the gap so we don't have any gap in the intra-articular part of ours. You see the lateral position, 2 olive wires, and we have, look to the tibial plafond, the articular reduction, perfect articulation. I still have this bone gap. Forget about it now. Then we apply the frame to the proximal part, to the 2 olive wires and the first wire. We apply them. The first wire, we do traction. We do we tension the wire for 130 kilograms, and we put the frame of the proximal part. So we temporarily fix the proximal part, then we apply the frame. You see two opposite eleve wires. See the fixation. Then we start to apply the frame to the distal part. So we have proximal and distal. Then look to the diaphysis. We push the diaphysis, which was displaced medially. We put an olive wire, then we tension it from the opposite side till we have a reduction of the two cortices. So we put the frame on the distal part, just with one wire in the distal part, and then we put an olive wire and push this segment till we get a reduction. Look to the lateral, the sagittal plane. We have displacement. This fragment is displaced with a bone gap. What's the solution? In this situation, we can move the frame, the proximal segment in the sagittal plane, flexion and extension till we correct the deformity. You see, we changed the proximal ring in the sagittal plane till we get reduction. And again, we have acceptable reduction, and in the AP and lateral, but we have a gap. Now we decided what to do with the gap. Compression. You see, in the operating, we close the gap acutely by doing compression between the proximal and distal part. And look, we end up with compression, and we wait for a couple of weeks. We consider the fracture as a corticotomy or closed corticotomy. And we close the gap, and we had compression, and we wait for 2 weeks till healing starts. Then we start distraction. Gradual distraction, 1 millimeter per day. And we observe the bone formation in the gap. Look, the bone formation, very good bone formation in the distraction gap. So we use the fracture as a closed corticotomy to correct the bone gap. And this is complete union and bone formation. This is what we do. This is what we usually do. Closed reduction techniques. In intra-articular fractures, comminuted, especially comminuted, we can do the tactics, closed reduction techniques before and after the operation. After the operation, we don't take the patient to the operating theater again. We correct it 1 millimeter per day. Now we have to go to the answering the 5 questions about the ligamentotaxis. What about the ligamentotaxis? It's a myth. Most of the paper, they talk about ligamentotaxis as it is magic or something. So they put even femoral distractor or the frame up and down and do severe distraction. I've tried that before. Indirect reposition of the displaced osseous fragments through distraction when the ligaments attached to these fragments. As I've told you before, in comminuted fragments, many of the fragments are not attached to the soft tissue. So this hypothesis is not valid. There is no proof for this hypothesis. So in many cases, distraction cannot reduce the fracture. Like this comminuted with tongue-shaped fracture calcaneus. You have to do this fulcrum to correct it. Ligamentotaxis will not correct it. This patient with tibial plafond comminuted fracture was treated by ligamentotaxis, and look to this picture. They put the frame up and down and they do severe distraction, but look, totally displaced, totally displaced. So ligamentotaxis usually cannot reduce the comminuted intra-articular fracture. And sometimes you have to do minimal invasive technique. We did arthrodiastasis first and it's no reduction. So you have to do invasive technique. You open, rotate the fragments and correct it. Don't be dogmatic. What about the metaphyseal gap? You look to this picture, comminuted intra-articular fracture with metaphyseal gap. Again, with polytrauma patients, comminuted femur with distal intra-articular fracture, comminuted tibia. Failed reduction. This patient was treated by external fixation, minimal invasion, and plating. And look to the reduction. Displace the fracture coming after 5 weeks. What are you going to do? And this is infected, unreduced fractures with 8 previous operations coming after 1.5 months. These patients had 8 debridements, 2 plates. And look to this gap. It's more than 1 centimeter, maybe 2 centimeters gap in the sagittal plane, and infected with 8 times debridement. And they claim that if you have this fixation and you repeat the debridement, this will solve the problem. It's not solved. It's unreduced infected fracture. Now, as we've told you, closed reduction using ligamento-taxis is not the solution, like this picture. In this picture, the first step in treatment was to remove the under anesthesia. Once we removed the fixator and the distraction, look to the picture. Very good reduction. You see, very good reduction because we just removed the distraction force. Then we used opposite olive wires and hybrid fixation. And then we have a gap. We put paste, 2 packets of synthetic graft in the, and you see multiple olive wires, and you reduce the fraction. Now we have perfect anatomic reduction. Again, non-invasive treatment. Look to non-invasive treatments. This is periprosthetic multiple fractures. We put the frame on and we have complete union. There are many techniques for indirect reduction techniques. Multiple olive wires, as I've told you, 2 opposite olive wires here after reduction. Arched wire technique. You put the wire and bend the wire. Then when you tension it, you push the segment like this one. You see here. You have a gap in the sagittal plane, more than 1 centimeter. And then we remove the plate. We put multiple wires in the posterior part. Wire in the posterior part, another wire in the anterior part. In the posterior part, we push the wire, we curve the wire anteriorly. And then the anterior part, we curve the wire posteriorly and we tension them. So we had anatomic reduction. So failure of open reduction, you can do closed reduction. Can you imagine? It's the opposite way. We always learn that if you have failure of closed reduction, you do open reduction. But here I'm going to teach you. If you have failure of open reduction, you can do closed reduction techniques. If you have a large fragment displacement, you have to use many olive wires. If you use one, you are going to have rotational force. So 2 or 3 wires will do. The direction of the wire usually depends upon the direction of the displacement. So if you have a displacement in AP and the lateral, that means you have a displacement in the oblique plane. So you have to direct the olive wire according to the real plane. Usually we have the displacement in one plane, not on the AP or the lateral, it's in between. Like this picture, this patient has displacement in the oblique plane, so you used just 1 olive wire in the oblique plane. Like comminuted tibial plafond fracture, we did manual distraction first, as you see here. Opposite olive wire opposite each other to correct the tibia. You see the opposite olive wires, many of them. Then closure of the gap and the correction of the varus deformity by this olive wire. We push it laterally, so we corrected the varus deformity, but we still have this displacement. Now we closed the syndesmosis by 2 opposite olive wire at the syndesmosis. So we closed the syndesmosis by an olive wire in the fibula and olive wire in the tibia, and we tension them opposite each other. You see here, we close the syndesmosis. Now we want to do anatomic reduction of the fibula. So we put an olive wire here and we push the fibula by tension on the opposite side to reduce the fibula. You see gradual tensioning and the correction of the fibula. Look to the syndesmosis, closed and compressed. Look to the tibia, comminution, and look to the fibula. So you can reduce all the elements of the fracture. This is closed intraoperative reduction of the fracture. Look to the sagittal plane. We still have a gap. If you have a gap, you have to put wires. This is very important. You have to put synthetic bone graft. We put synthetic bone graft here. What about a metaphyseal gap? Sometimes you have a huge metaphyseal gap. It's beyond the bone substitute or the bone, but you can use bone transport. Like this patient with this severe comminution, arteriography was done because we were for fear of injury of the popliteal vessels. And this was the reduction. First, aspiration of the effusion, distraction, manipulation, 2 olive wires opposite each other. Corticotomy was done first. You have a gap, then corticotomy, lengthening, and the correction of the deformity. Polytrauma patient, you see here. And we have a floating knee injury, and intra-articular distal fracture, and segmental fracture, severe injury. Again, we use the external fixator using the closed reduction techniques till we have complete union. Polytrauma patient, distal femoral fracture, proximal tibial fracture, and valgus deformity, and tibial fracture again in one patient. And we have distal radial fractures. Again, we can put the frame on and we fix the intra-articular fragments. We correct the valgus deformity and we correct the distal tibial fracture. Again, closed reduction techniques using multiple wires in the lower radius. Unreduced and metaphyseal defect. If the patient comes with infected plating, like this patient, and the multiple and the metaphyseal defect and hybrid fixation, we removed the fixator and we removed everything, and we did reduction using the frame, as you see here. And this is the final picture, complete union. Infected intra-articular fractures. This is a real problem. What's going to happen if you do open reduction, internal fixation, and you have infection of the plates? The rule and the conventional teaching is if you have stable internal fixation, in such a case, you have to do debridement once, twice, and many times. And this was exactly happened in this patient. This is 26 years old, young guy. And this guy is working about 12 hours per day. And he had this comminuted fracture, tibial plateau. And he was treated by double plating. Because he has, you see the corona, the sagittal plane. So they put another plate anteriorly to hold these fragments. But you have severe displacement here. And this patient has severe infection and sinus formation. And he had debridement of the infection 8 times, 8 times. So he presented to me after 6 weeks, 6 weeks of the internal fixation. We told the patient that most probably this knee is going to be stiff because of the long-standing problem. You see here, we took the patient to the operating theater. We did debridement. We removed everything. And then we did closed reduction techniques. You see here, multiple olive wires. We put the frame proximally and distally to allow for immediate mobilization of the knee. You see the hinges here. We cannot fix this knee for such a longer time. This knee is fixed for about 6 weeks. So we decided to move the knee immediately after the operation. Coming to the sagittal plane, we have a gap. The gap is about more than 1 centimeter. So we did closed reduction techniques. We pushed a wire on the anterior segment, another wire in the posterior segment. The wire in the anterior segment, we bend it posteriorly. And the wire in the posterior part, we bend it anteriorly. And then we did tension, 130 kilograms, both wires at the same time. So gradually, with the straightening of the wire, it closed the gap. So it's a bit strange because I know that classic teaching, if you have failure of closed reduction, you do open reduction. But I'm going to tell you the opposite here. If you have failure of closed open reduction, you can do closed reduction. See again the reduction. And this is after removal. The patient is bending his knee about 90 degrees. And this is 1 year after the operation. Look the patient, he has more than 90 degrees movement. Look to the articular surface and no pain. And he's working. He returned it back to his job. So again, in cases of infected intra-articular fractures, there is great important role of external fixation. What about the complications of intra-articular fractures? What about malunion? If you have an intra-articular fracture with malunion, this patient is 46 years old and he has this fracture, which is malunited. You see, there is varus angulation and there is flexion deformity. And the patient started to have unicompartmental osteoarthritis. And this is very important. So we took the patient to the operating theater. We removed the plates. We removed most of the hardware, and we did corticotomy. And from the corticotomy, we corrected the deformity. And then we did lengthening, you see here. Look to the open wedge, because we corrected the flexion deformity. You have an open wedge here, you see. Open wedge anteriorly, because you have a flexion deformity. And we corrected the varus deformity. And we have wedge also here and lengthening. You see the bone formation. You see the bone formation at this age. You see after removal. Complete union. It's the same length on both sides, and we corrected the deformity. Because if you wait a little bit, you are going to have, this patient will need total knee replacement in this young age. So in cases of malunited intra-articular fracture, we can treat the patient. Sometimes we treat the patient with intra-articular osteotomy, but in this case, we use peri-articular osteotomy till we corrected the deformity. In conclusion, the rule of scan, span, and fix is not a rule. It's just some sort of repetition of the same words again and again and again. The role of external fixation is not just span. The problem is why we call everything external fixation. If you search in the English literature, they call all the external fixators the same. So if you just have 2 pins above and 12 pins below and casting, they call this external fixation. This is not what I mean by this lecture. If you mean by just putting 2 half pins above and 2 half pins below, just to facilitate nursing or changing the dressing of the wound and to watch the wound, why don't you put a cast and a window, and that's enough. Ligamentotaxis is not effective in all intra-articular fractures to induce the reduction. Remember, take it cautiously. Ligamentotaxis is not effective in many of all intra-articular fractures. Besides, you don't need severe distraction. I have faced that myself. If you have severe distraction, you might have a vascular or neurovascular problem. And sometimes severe distraction can displace the fragments again. Because like a case I've shown you with intra-articular calcaneum fractures, because you have a small fragment not attached to the soft tissue, and it's rotated 180 degrees. So how ligamentotaxis can correct this? Displace the fragment? No way. So there are many limits for ligamentotaxis. Don't take it for granted. Circular fixation and indirect reduction techniques can be used as primary and definitive treatment of intra-articular fractures in about 50% of cases. Remember, if you have the experience, you can use it as a definitive treatment of fractures. Even in polytrauma patients, they always say, the patient, it's going to take such a long time. Who told you? If you are a professional, it won't take such a long time if you do it every day. The problem with external fixation, then we teach the external fixation, we teach it to the residents when they start the residency, and they tell them this is a very simple and easy procedure. You just put 2 half pins above and 2 half pins below and a rod in between, and that's it. The second problem, most of the people who teach external fixator are not doing external fixator, they're doing internal fixation. So they are teaching external fixation as a preliminary step to do internal fixation. Malreduced, neglected, and infected cases can be treated successfully with indirect and direct reduction techniques. So it's not the rule. If you have malreduced or neglected open reduction, you have to do an open reduction again. You can do closed reduction techniques in such cases, which is the opposite way of thinking. Management of intra-articular fractures. If you want to manage intra-articular fractures, you have to learn non-invasive, minimal invasive, and invasive techniques. Don't tell me that you usually treat the intra-articular fracture with minimal invasive technique. This is not true. If you are planning minimal invasive technique, you have to learn the fully invasive technique, because your percentage of failure. I'm planning to do minimal invasive technique. I did minimal invasive in calcaneum fracture, but there is failure. You have to do the full approach. If you are not able to do the full approach, don't do the minimal invasive technique. The real merit of the use of circular fixator as a definitive treatment is closed operative treatment of fractures. Gradual postoperative reduction during follow-up is also possible without anesthesia or analgesia. This is the real merit of external fixator. Not just to put an external fixator as a cast. This is not an external fixator. It looks like a sham operation. It's not true. This is not external fixation. The real merit of the use of circular fixator as a definitive treatment is closed operative treatment of fracture without incisions, and also gradual postoperative reduction without anesthesia or analgesia while you are in your outpatient clinic. You don't have to take the patient to the operating theater again if you don't have anatomic reduction during the operation. Finally, you've learned a lot of conventional treatment. I want you to think out of the box. If you want to think out of the box, get out of the box. Again, if you want to think out of the box, get out of the box. Thank you. Finally, I would like to thank Sanofi Aventis Pharmaceutical Company for giving me the chance to give this lecture. Thank you.